Hi, T4 friends. Welcome to our episode of Tots to Teens Tidbits. Today we're going to be talking about putting the pro in pediatric dermatology procedures. And we all know that in pediatric dermatology, there can be lots of tears and lots of fears. But hopefully after this talk, there will be less of both, not just for the patient, but also for you as the physician taking care of the pediatric patient who is needing a procedure. So the approach to the patient in pediatric dermatology procedures, luckily, is mostly common sense. So really just being sensitive, patient, supportive, and communicative will get you really very far with a child. So again, just know that you are going to have to slow down. Your typical pace that you usually have with an adult patient is not what is going to be well tolerated by a child. Um, let them know that you're there to support them. And then also communication is really key in these scenarios so that these children know what to expect. Also important is the incorporation of developmental pediatrics because we need to consider the needs and the age of each child because they're not miniature adults. So developmental considerations in infants, birth to 1 year, believe it or not, they do have stressors, separation from family, change in routine, and then also the fear of abandonment. And they have shown in babies that are NICU babies that they do develop stress responses. So they get multiple heel sticks when they're in the ICU. And they've shown that after just 2 heel sticks, on the third time when they go to use the alcohol swab on their heel, that their heart rate actually goes up and they have a stress response. So they also have memory that affects them physiologically. So don't underestimate that in a child. And I will tell you the best thing to use for kiddos when you're doing a biopsy on a little one, especially an infant, when you can swaddle them, is to have sweeties, which is basically just a sugar water available. And you can have that on a gloved finger. A nurse can do that for you if it's an inpatient. You can put it, dip it on a pacifier. But that actually really reduces the stress of the biopsy for a baby. And then toddlers, that 1 to 3 year age, this is a really tough time to do a biopsy on a kiddo because they're not yet old enough for you to really explain and for them to understand, but they don't like to be separated from family or their normal environment. So usually keeping the parents close by is helpful. They certainly don't like loss of control or change in routine. They fear being abandoned. So again, keeping parents close by is a good recommendation. And then everything seems permanent to them. So nothing is short term. So toddlers can be challenging, but if done right, they can also, get through a procedure really pretty well. Preschool, this is when you can kind of start to reason with a child about things, but a lot of times they start to have these unrealistic imaginations and they think up scenarios that aren't necessarily true. They certainly are probably not going to understand why they have to have a procedure. Explaining that is probably not going to get through to them. So preschool kiddos, again, can start to be on the same page with you, but that can vary quite a bit. Finally, school-age children. Here, again, communication is really key because they really do understand and they can be your best ally in this. If allowed to participate in the process, they have, their stressors or fears associated with loss of their body parts or body functions. They have anxiety around illnesses and the effect of medical treatment. They certainly feel stressed when they feel helpless or loss of control, loss of respect. And and then they can sometimes become angry. And again, they want you to listen to them. So they may refuse to participate if they don't feel like they kind of have a stake in the game, if you will. And then also certainly fear of anesthesia. I can tell you, I had anesthesia 2 years ago for the first time, and it was scary for me. Certainly modesty concerns, and this can be quite significant. So something to definitely remember that, modesty is an issue. And then, of course, no one likes disrupted routines, but being separated from their friends can really be a big deal for them, even more so than other age groups. And then adolescents, we're approaching those tween years, early teens, and they really do worry quite a bit. But sometimes they're reluctant to ask questions because they don't want to sound silly in front of other people. Certainly, there's a fear of pain, and then concerned about their privacy. So, surgical consultation, this is a great time to start to build that rapport with the patient. Regardless of the developmental stage, you want to start to build rapport with the patient and also their family. You certainly want to involve the child in the discussion, talking with them about, why they think they're there for the visit, getting an assessment of their maturity, their emotional status, and then a big deal is the parental interactions, because again, parents can be your ally in the room, or they can sometimes really make things more difficult. So those are important kind of soft things to look for. You're not necessarily going to ask questions about anything, maybe just, a question about, do you know why you're here today? But certainly validate the patient every chance that you have. That's a big deal for children to feel heard and seen and understood. And this surgical consultation will help you determine the best surgical approach. Can it be done under local? Are the parents going to be in the room? Are they not going to be in the room? Or is this going to require general anesthesia? Medical evaluation, also important. Luckily, in pediatrics, most kids are healthy, and it's less of an issue than if you're doing a surgery on an adult, but certainly pertinent history, their overall health. Important to ask about prior anesthesia, and sometimes they won't have had surgery. Maybe they had tubes in their ears. That's not uncommon. But certainly sometimes injuries, broken bones, and then asking how it was tolerated preoperatively and also postoperatively. Certainly asking about quality of scars, if they've had keloids, hypertrophic scars. And then most of them are not going to be on antiplatelets, but if they are, have them discontinue. A lot of kids, in those teen tween years are using NSAIDs for sports. So just important to bring that up. Dressings, letting them know about what the dressing is going to look like. And then also restrictions. And I was very strict because of learning from my mentor, Annette Wagner, who I love dearly. But you don't want to jeopardize the healing of a wound, and then certainly you don't want to jeopardize the scarring, because that is lifelong, as we know. So if they really can't stick with the restrictions, and I did 30 days strict no sports afterwards, and if they couldn't comply, it was always better to postpone, certainly for things that were a little bit more elective. So anticipatory guidance, this is a big buzzword in pediatric dermatology, and it basically just, means talking through what to expect. So always involve the child. Again, it's best to focus your attention on the child in pediatric dermatology situations. And, of course, the parent is a major part of a pediatric dermatology interaction, but you want to be talking to the patient that you're actually going to be treating. Tell them what the day of surgery is going to look like. Is it the outpatient nature, that they're going to be able to go home, that they're going to get a call from the office beforehand to remind them. I always made sure to call that evening when they got home. So I would collect the family's numbers and ask them the best number to call, and call them that evening just to check in on them. And that was always appreciated. And sometimes it prevented complications. And then certainly procedures, the procedural aspects, going over that step by step is important. And certainly you want to use age appropriate descriptions. We don't want to say a bee sting or a shot, just because, those are not pleasant things. So it's best to stick with a pinch when you're describing the injection for the local anesthesia. Certainly do not lie. They're going to figure out if you're lying to them pretty quickly. And if you have lied to them that this isn't going to hurt, then, you've lost their trust and they're not going to believe you for the rest of the procedure. And then that means they're not going to be as cooperative. And I know that a lot of times parents are the worst culprits of this. They're, want to tell their kids, oh, this isn't really going to hurt. But you do have to say, well, there is going to be a pinch to it. But then after that, you won't feel anything, and we'll make sure that you don't. So anyway, sometimes you have to dispel, the false facts that parents want their children to believe. And then again, review all those steps so that they know what to anticipate. And then following the procedure, again, go over the restrictions, what postoperative complications may happen and what that course may look like. And again, just eyes wide open is always better when we go into something. So again, just going over what could happen, and then just offer realistic expectations of what this is going to look like. Remember, you are going to have a scar. Those are all important things to remind them of. And then timing is everything, to minimize the surgical risk and optimize the surgical outcome. So age and developmental stage of the patient is important. And again, that's going to not only does their development impact their ability to handle the procedure will actually impact their emotional and social development. And if they have a positive interaction going through this, then they'll be able to get through procedures in the future, because it will show them that they can get through hard things. Certainly, under the age of 2, they're probably going to need anesthesia for an excision, and then certainly healing and resultant scars. So those toddler years are just really tough for excisions. They won't let the parents a lot of times do the dressing changes, or do what they need to. So I really try, unless I'm really concerned about a lesion, to wait until they get a little bit older, because again, temper tantrums are a real thing, and stitches can pop open when those happen. So, and then certainly cosmesis is always going to be better if wound care can be done appropriately. And again, involving the patient when they get a little bit older is important too, so that they can see the stages of healing. And then again, there's no absolute rules. There's no absolute rights or wrongs. And in the end, it's about giving the parent and the patient truthful information so they can make good decisions about if they want to move forward with removing a certain lesion, and what they're trading it for. So again, local outpatient procedures really pretty individually variable. And again, you want to use positive commands, which we're going to go over here, and do not give false choices. So key. But generally, girls around the age of 8 or 9 years of age are able to do an excision under local anesthesia. Boys are usually about 10 to 11. But again, this varies widely. And then certainly, if the procedure is going to be less than 5 minutes, you can restrain them. The best way to restrain is making them a burrito with a blanket. And again, a sheet is always preferred. papoose boards really are fairly archaic, and they really have the child feel a huge loss of control and autonomy. And then again, using your body, using the parent to kind of make a tent to cover up the area so that they can kind of be removed from the situation a bit. And then certainly if a procedure is going to be needing to be repeated, sometimes they need to have general anesthesia because going through it multiple times, like a one and done, is different than, oh, I'm going to have this laser procedure multiple times every few months. And then again, you want to think about the postoperative care and restrictions. And yeah, again, those toddler years are tough. I did a staged excision of a big melanocytic nevus on the occipital scalp, and the last stage, it looked beautiful, and that sweet baby just had a fit after the suture removal as they were getting in the car, and yeah, it dehisced in the central area, and that scar widened, and again, it made me regret that we didn't put that off a little bit later. So this is the examples of the positive commands. So again, we don't want to use negative phrasing. None of us like to be told no or don't. But let them know what you expect of them. And this can be really helpful. So instead of saying don't move, say please hold still. Don't touch. Keep your hands to yourself. Keep your hands on your knees. Keep your hands on your shoulders. Keep your hands folded together. So you can't stand up or just sit on your bottom. Again, you're just explaining what you expect, and it lets them be more compliant. And you can't go home until you drink. After you drink, you can go home. So again, the words that we use have a huge impact. So just be mindful of avoiding those negative phrasings and using positive commands. And then examples of false choices. Y'all, this can get you in big trouble. You really don't want to give choices that aren't really there. So are you ready to go? What if they say no? So suggested wording would be, it's time to go. Again, just setting that expectation for them. Can the nurse listen to your heart? No. Then what do? Then it becomes a fight, right? And you've taken away their autonomy. So the nurse needs to listen to your heart now. And then certainly never end a statement with okay. Just because if they say no, it's not okay. Now you need to go against their wishes and violate their autonomy and their sense of control. So again, don't ask if something's okay if they really don't have a choice in the matter. And then again, anesthetic considerations. As we know, topical anesthesia is a real godsend in pediatric dermatology, local anesthesia, regional nerve blocks. These can be quite helpful. Not done a whole lot, but can be quite helpful. And then the sedation and the general anesthesia for the younger kiddos. So Emla, it's prilocaine and lidocaine. It is available by prescription. You can get it over the counter in a lidocaine mixture alone. And they've shown that the Emla and LMX are equally effective. The Emla is, takes a little bit more time, where the LMX is 30 minutes. And you can occlude it, of course, and that enhances its effectiveness, or you can leave it non-occluded. So again, complications of topical anesthesia. So there are kids that if you use it on too big of a body surface area, they can have lidocaine toxicity, and very rarely you can get methemoglobinemia, and this is a board question. The treatment is methylene blue or ascorbic acid, and this happens very rarely, but it happens more commonly in premature infants. They get mottling, perioral, and acral cyanosis, and then certainly I have seen petechia and purpura underneath the LMX after you remove the dressing. And that can be, really troubling when you first see that. And then certainly if you get a high enough level, you can have seizures. And this has been reported in pediatric derm offices with patients that have, used a lot of topical LMX for curettage of molluscum. So again, realize that there are maximum doses based on the weight and the age of your patient. So if you're going to be using it before a local injection, you want to, describe it as frosting on a cake. So basically they take a little bit, rub that in first, and then they put a big dollop on top. And they have shown that parental application at home is just as effective as having it done in the office. Again, you can dispense it from your office. There's certain rules around that. You can get it over the counter, or you can write a prescription. And I like to give that prescription at the consultation visit, and then they have it ready to go on the day of the procedure, and they can apply that at home before they head into the office. And then local anesthesia, there's really no FDA approved indication for use in children less than 12 years old. We know that, this is not uncommon in pediatric dermatology to use medications off label. Commonly utilized types of lidocaine, certainly the 0.5% lidocaine with 1 to 200,000 epinephrine. And you can use Marcaine, which is a little bit longer active. Certainly local infiltration is what is done standardly. There have been some studies that looked at iontophoresis, so that, if you have a really needle phobic patient, but this really is not realistic in the real world. So again, certain ways to make this less tears and less fears for both the provider and the patient. So, as far as the injection, the way we do it is very important, and our technique matters. So again, really always using pre-op topical anesthesia, buffering your lidocaine with sodium bicarbonate. Make sure that it's at body temperature. Some offices will have aliquots where they store them in the fridge, and you really want to make sure it gets to room temperature. Slow infiltration is key. Sometimes you're not going to have that option. If you have a toddler that you have very limited time, you're just going to have to put that in. But the slower, you can put it in if you have a compliant patient that's going to lay still, the better. And then certainly 30 gauge needles are really the way to go. You can freeze them, that it hurts less. Definitely put a bevel on the follicular orifice if you have an option. And then again, going perpendicular to the skin. And again, I learned this from my mentor. So thank you, Annette. You saved many a child from more pain with biopsies and local anesthesia. But if you go perpendicular, you're going through less nerve fibers, where if you're going in horizontally along the skin, you're just, hitting many more nerve fibers as you go. And then once you get your wheel raised, you can go in around it to extend it. And then certainly local distraction, we know that the nerve fibers that sense pain also sense the vibratory stimulus. So if you shake the skin next door to where you're injecting, that can really help. And then certainly the buzzy tools, those are great to have available. And then again, regional nerve blocks, you want to use plain lidocaine. Certainly if you're doing a digital procedure, a nail procedure, this is when we use this the most, and it does give long-lasting postoperative pain relief. Sometimes if you don't get in the right area, you're not going to have the best result. And again, this takes a really compliant patient. And then preoperative sedation, certainly acetaminophen beforehand can be helpful as far as the post-op pain and just what they're experiencing during the procedure. Nitrous oxide has been shown to be superior to any anxiolytic. But again, a lot of times we don't use either one in the real world. And certainly people talk about conscious sedation, but then you don't have control of the airway. So it actually becomes more risky in these procedures that we do dermatologically. So if you're thinking about a patient needing to be sedated during the procedure, you really should be thinking about general anesthesia. And then general anesthesia, again, balancing the risks and benefits. Best option if a procedure is required under the age of 7, if there's multiple lesions, if it's going to be repeated. And again, this is going to vary quite a bit. You can see here, just letting them play with the mask beforehand. We would always talk about, in Houston, NASA and being an astronaut. And again, if you can get child life involved, they will be your best friends in this. And certainly that's the beauty about doing procedures at a pediatric hospital. Everyone is attuned to developmental stages of children. They've also shown that there's less complications. So again, if you're going to be doing general anesthesia, best to be doing it in a pediatric center. And again, the benefits, painful procedures, you get less of that stress response. It allows you to have better pain control. It helps, impact their painful memories that can then inform future painful stimuli. Again, because they don't remember, they're a lot more comfortable. And it can really improve the rapport between you and your patients when they come in for a post-op visit, because you haven't had to hold them down to get this procedure done. And it certainly improves safety and has better outcomes, because when we're thinking about a child being awake and moving around and you're talking to them, you're a little bit distracted from the actual procedure. So again, certainly that is a huge benefit of general anesthesia. Risks, very low risks. So we know that, the risks go down if you have trained pediatric anesthesiologists in a pediatric hospital. Certainly the healthier the outpatient subset that you look at, the less complications you're going to have. And again, a lot of anesthesiologists will talk about toddlers eating a hot dog or driving in a car on a busy highway. And then this is an older study, but it was nice that, Barry Cunningham had looked at, nearly 1,000 procedures in kids, and 90% had no clinically relevant complications. And really the biggest one was nausea and emesis, but certainly no serious or life-threatening events. The other risk of general anesthesia that we know more about is developmentally, neurodevelopmentally. It does have an impact. So, and they have shown that, repeated procedures, the baseline status and health of the patient impacts that. And then certainly the length of anesthesia. But they've also shown that short procedures can have some impact. So definitely something to be cognizant of and not to take lightly. And then lesion considerations, you want to think about the growth of the lesion. And I always kind of explain that the scar is going to grow with the child, or the lesion is going to grow with the child. And then certainly risk of recurrence if, a nevus sebaceous, if you don't get all of it, and sometimes you don't really see all of it when they're young because it doesn't have that hormonal stimulation, you may get recurrence, and it's important to let the families know that. Certainly malignant transformation, if you're worried about a lesion, the sooner the better. And then cosmesis, we want to make sure that patients are fully aware that they are trading this lesion for a scar, that there's no magic erasers out there, and letting them know that if they're getting bullied or made fun of for the lesion that we're wanting to remove, that they may also get bullied or made fun of for the scar. So again, they really have to understand what they're getting themselves into, because we know that scarring and also having a skin lesion can impact self-esteem. Laser considerations, again, age of the patient, type of the lesion, and extent. So if they're really extensive, you're going to want to use general anesthesia. Certainly you can use topical anesthesia and parental involvement if the lesion is small. Swaddling of an infant is great. And then again, a little bit older child is really important to explain to them so that they can comply and have the best outcome. So pulse-dye laser, port wine stains usually require an average of 8 treatments beginning in the first year of life. Does seem to have a better cosmetic outcome. Another time to consider it is ulcerated hemangiomas. Luckily, we have treatments that are non-surgical that can help with ulcerated hemangiomas, and you do have to be careful with laser and have experience in treating ulcerated hemangiomas, or you can make them worse with laser, but it can also be a great way to heal them up. Certainly, facial telangiectasias do great with pulse dye laser, spider angiomas, but again, it can remove the pigment if they're tan. So I do like to do that in the fall or winter months. Pyogenic granulomas, so lasers work great on this. So that is certainly an option. You can remove them, snip them, depending on the lesion, but laser works great. And you can compress with a glass slide and actually then laser through the slide, and that gets it kind of through and through the lesion. So I usually do a few pulses without, and then place the glass slide and do some pulses through the slide. Certainly warts are really painful. The laser is really painful. And usually children need general anesthesia for that. And then certainly scarring can be treated with laser, and that's most effective if you have facial scars, but can be done in other areas. So just a few common sense tips to lessen the tears and the fears as we wrap up our Pedi Derm procedures for the tips for tots to teens. So tip 1, really, if you're going to be doing a lot of procedures, it is best to really set aside a half day for office-based procedures if you're doing pediatrics, because, it usually always takes longer to do a procedure in a child because there is so much explanation and hand-holding that goes along with it. And then certainly when we're rushed, none of us are our best selves, so make sure you schedule yourself enough time and factor in that you're gonna maybe have to sit down and explain things to the patient again and again, always longer than anticipated. And then certainly always have sufficient support staff for assistance. And I like to have them in the room at the beginning of the procedure, because if a child starts acting out, or having difficulties complying, then you have all the sharp instruments out and you don't have extra hands. So it's best just to have them kind of next to you and just say, I'm going to bring some friends in the room and they're here to help me if we need it. And then this is really important. So basically, when the patient first comes, if you're going to be applying the LMX, they can bring the patient into the room. Child life can come into that room. And then basically you want to talk to them before the procedure in a separate room, because once they see the tray, that's all they're going to be able to focus on. Like, they have lost the ability to listen to you. And again, sit down in a chair, explain again on their level what to expect, get that consent sign, and then give them the option to answer any questions. And then I always then, as we're getting them all settled and consent signed and all that, I'm like, let me just go make sure that our next room is all set up. So then I go and I check that, and I make sure I have the chair set out, like if mom's going to be up at the head of the bed reading a book, have that chair already there, have your chair, your stool out and ready to go, because we do want to limit movement around the room and use our time efficiently and effectively. And then again, you want to have all your instruments laid out on the tray, loaded with the suture to decrease the procedure time. So again, common sense, be ready to go, and then put a towel over the top of it so that they don't see the tray as soon as they walk into the room. And again, just don't set up your surgical tray or draw up the local in front of the patient. And again, cover all the instruments to reduce anxiety for when you're getting them settled in the bed. And then try your very best to use towels, to use a drape, to use your body, to use a book that the parent holds. Because really, once they see the needle or syringe, that's where you can lose them. So it's best to, just not have them see that if possible. And then also check your pulse and your heart rate. So if you're relaxed and confident, then your mood is going to translate into the patient's mood and they're going to react positively. And then again, carefully watch the words you're using. If a patient is, awake, you just don't want to say the words bleeding or knife or cut, because then they're going to hear those words and start to get anxious. So just be really cognizant of the words you use during the procedure. And then again, most kids do best when the parents are allowed to be in the room. There are rare exceptions. And again, that's what your pre-op consultation part of it helps you determine. It's really not a great idea to have the parents engage in restraining the patient. For short term, yeah, you can give have the parents give a kiddo a bear hug if it's going to be a short procedure, or you can have them kind of bear hug if they're going to get a laser. But again, that short term, the best place to have them is like in this photo here, to have them seated near the head of the bed to offer the child distraction and support if needed. And then again, before you uncover anything, get your patients comfortably seated on the table. Again, the relaxed atmosphere and tone. If they have music that they want you to play, ask them what their favorite kind of music is. They can bring in a personal pillow, blanket, or stuffed animal. And then again, allow them to participate in decisions when they can. So that gives them a sense of control. If they, you talk about, okay, what color, stitches do you want? Or what color dressing do what color bandage do you want? And again, it just gives them a small bit of control. And then again, engaging that child in conversation at an age-appropriate level. It helps them talk through procedures and do hard things. So it helps them develop coping skills to know that they could get through something. But again, just engaging them in discussion about what their hobbies are, what they like to do, what's their favorite food, what's their favorite color, what's their favorite video game. And a lot of times something will hit that you also like, and that can lead to a real good conversation. And then certainly there are creative measures taught to us by our child life specialist friends. You can use bubbles, books. Certainly the I Spy books are great. Visual imagery toys, certainly handheld devices, and games are great. And then again, position yourself in the drapes to obstruct the patient's view of the surgical field. Keep the tray and the materials and specimens out of the view of the patient. And then again, make sure you hide any blood-tinged material. And before you get them up, they're going to look over at the tray as soon as they sit up, and they're already going to be a little bit woozy. So again, we don't want them to see a bunch of blood. So just be cognizant of that, to cover the surgical tray before you set them up from the supine position. And then again, tip 10 here, clearly common sense. Perform the procedure as quickly as possible, but don't sacrifice good technique. Sometimes, and it's more in the toddler scenarios, or the early preschool years, where sometimes it's about just getting the procedure done. But again, do your best to have good technique. And the less time that you have them laying on the table, the less time they can, be anxious or restless. And, as their anxiety increases, their attention span is going to decrease. So again, having everything set up beforehand and ready to go helps you with your, your efficiency and keeping them on the table less time. And then choose a suture based on the site. So the face, the best is interrupted. I've used a lot of skin glue on the face. The scalp running cuticular is great. And then the extremities, the axilla and the groin running subcuticular. These are, usually the best for those areas, but every situation is going to be different. And you're going to have to determine that based on the clinical scenario. And then certainly deep dermal sutures to maintain strength of the wound in a young active child. So again, the workhorse of wound healing is our deep dermal sutures, but even more so in a young active child. And then the skin in children is certainly more reactive. So try to limit your epidermal sutures. You can see here that reactivity of a child. This was just the sticky tape around the field, irritated them. And so applying steri-strips for added support. I like steri-strips. I use a lot of steri-strips. And then again, use bulky dressings to slow them down. Once they get up off the table, they're not going to be thinking about this anymore. That's going to be in the past. And so again, slowing them down with bulky dressings is always helpful. It should be left in place for 48 hours, that initial dressing. And then again, you want to immobilize joints and just really limit how they can get their hands onto things. So less hands on wounds equals better wound healing. And then again, really important to provide written instructions, even though you've gone over it multiple times in your consultation, before the surgery, after the surgery, write it down. Tylenol for pain, surgical site, keep it dry and covered, the activity restrictions for 30 days, and then go over the strict UV protection for 1 year. And then again, suture removal is important. We know this. So less time on the face, about 5 to 7 days, trunk and extremity about 10 to 12, and then scalp 12 to 14. And a tip there for getting the, a lot of times they can be real crusty on the scalp. And to get rid of that hemorrhagic crusting, you can take a little bit of dilute hydrogen peroxide and use it on a Q-tip to help get some of that loosened up, or you can use it on a gauze and let it sit there for a little bit before you remove the sutures, and that'll help them come out a lot easier. Again, that suture removal, the moistened gauze if they're crusted, hydrogen peroxide in hair-bearing areas. I always reapply steri-strips. Again, just a little bit of extra reminder to slow down, go over that 30-day postoperative restriction. And then wound healing, certainly as soon as that wound is healed up, I like to start scar massage with a silicone-based scar. And then strict mineral-based sunscreen for a year. And then usually, again, this will vary, but usually follow up to just check in, make sure things are healing, make sure that they're pleased with the scar and it's moving in the right direction. But yeah, it's going to vary depending on the patient and the situation. And that wraps up our Tots to Teens tidbits. I hope you're all feeling like pros and can go out and do pediatric dermatology procedures with less tears and less fears. Bye.